Welcome again to a very special education session sponsored by CHM Community Health Media. Today is a very special session, very special, because I have one of my dearest colleagues, not only a colleague, he's a brother of mine, Dr. Ahmed Elkhanany from Baylor College of Medicine, an institution I love and I used to work at. And today we're going to have an excellent discussion talking about ESR1 mutation, a very important mutation in hormone-positive, HER2-negative breast cancer. And we're going to talk about the new kid on the block that's going to be coming, drug called Camizestrant. Dr. Elkhanany, take it away. How are you doing?
I'm doing great. Thank you. Thank you so much, Jason, for this introduction. I wanted to just give a brief intro about myself. I'm one of the breast medical oncologists at Baylor College of Medicine. I have the privilege of knowing Jason and knowing the team here at Houston for a couple of years now. And if you don't know Jason, then you're missing out. And thank you for having me and for having this important discussion.
No, thank you for being here. And we've been wanting to do this for a while. Finally, it's happening. Finally. All right, so it's a very important space that we're talking about. So it's important to lay down that space. So what does it mean to have an ESR1 mutation? What is an ESR1 mutation and how does it happen?
Right, it's I think ESR1 mutations are one of these novel discoveries that really changed how we understand breast cancer care. And interestingly, a lot of that work was actually done at Baylor College of Medicine. The team studied endocrine resistance for a long time. So I would like to think of ESR1 mutation as the same way you think of an antibiotic resistance, right? You got a bunch of bacteria, they're sensitive to an antibiotic, and then eventually they become resistant. Well, how did that happen? Well, one of them might be resistant to the antibiotic, and then you select that one out. And in a similar way, that's what ESR1 mutations look like. And that's why they have the term emergent, because they emerge. They're not there. And in fact, if you look at the research, when you see an endocrine, an ER-positive breast cancer patient, they're almost never, at the beginning of their therapy, they almost never have an ESR1 mutation. It's like less than 1%. Someone walked through the door, new diagnosis. But then, you give them endocrine therapy, you're killing all the endocrine sensitive cells. And at some point, some of the cells might have that abnormal configuration at one or, another particular point mutations. And then what happens is they become what's called ligand independent. So that means, aromatase inhibitors lowers the ability of the cells to kind of receive estrogen, that it's not, decreasing the estrogen produced. But and that's the ligand, right? But the ESR1 mutation makes the estrogen receptor active, even if that ligand estrogen is not there. So as you're depriving the body of the estrogen by using aromatase inhibitors more and more, you're essentially soliciting more of these abnormal cells to survive, and the other ones that need the ligand will die off. So with treatment, you get more emergence of ESR1 mutation. In the metastatic setting, at that first line, somebody, who just got diagnosed with ER-positive advanced breast cancer, there'll be about 5% chance of having an ESR1 mutation. But then you throw aromatase inhibitors, you throw your endocrine therapy, and by the second line, they're almost 40%. So this is how ESR1 mutations work. Now, there are actually different flavors to ESR1 mutations. There is what's called fusion mutations. There are point mutations. There are different types. Some of them are more ligand independent, more active than others. But they all share the fact that they make the cell, the endocrine program, active, independent of estrogen. Now, that's a problem, because what are you going to do for these cases, right? I mean, you get you have a patient walk through the door and you do a testing and you find an ESR1 mutation, which means that if you throw standard endocrine therapy at these patients, they're just not going to do well. So this is the current landscape of what the mutation has been.
Shout out to Dr. Suzanne Fuqua. She's the one who discovered ESR1 mutation at Baylor. She was one of my prior mentors, and I greatly value her insight. But you're right, all ESR1 mutations don't come in one flavor, right? So there is multiple different ESR1 mutations. Historically, about 50% are this D538G mutation. And this one, fulvestrant, does have some activity against. But the other 50%, you have those Y537SC and N. These are the one where fulvestrant has no activity essentially against. And forever we didn't have a target for those. So can you tell us a little bit about the landscape of what is right now approved and when can we use them? Mainly talking about elacestrant and imlunestrant.
Yeah, so, for a long time, so you touched upon fulvestrant, right? As you mentioned, there are different mutations, and fulvestrant was thought for a long time to be the only active agent against ESR1 mutations, to varying successes. Fulvestrant is a SERD, so instead of decreasing the ligand, it would just destroy and remove the receptor altogether. I always tell my patients that if you have a door and that door is like letting in the estrogen, well, fulvestrant will remove the door and put a drywall instead of it. And for a long time, that has been the standard of care for some of these patients. However, we know that it comes short. So over the past couple of years, a lot of effort has been put in trying to make it a better version of fulvestrant. And while at it, trying to make it oral, so that everybody knows that fulvestrant being injected once a month is not the funnest thing. It's 2 injections, by the way, not 1, right? And patients are not really excited about it. So some of the early drugs that came into the market is elacestrant. So that was one of the first oral selective estrogen receptor degraders. And elacestrant was tested in the Elegant trial, Emerald trial, I apologize. And the Emerald trial looked at patients who had really progressed on the first line of endocrine therapy. And they initially were not specifically looking for ESR1 mutations. But over the course of the study and as patients came in, they found that there are selective benefit they're seeing more in patients who have ESR1 mutation versus those who are wild type ESR1. And a study was comparing elacestrant to fulvestrant, and there was an improvement in progression-free survival. Hazard ratio, I believe it was a couple of months improvement on BFS. So elacestrant got an FDA approval as a second line for patients who have an ESR1 mutation. Over the preceding few years, a lot more similar agents, oral SERDs, are starting to come into the market, and the one that took the second, I would say, spot after elacestrant was imlunestrant, which is another oral SERD that also has been tested in multiple different settings, including in the later line setting, patients who have progressed on AI and a CDK4/6, also all comers, not necessarily SER1 mutations. And then the pivotal trial with the EMBER-3 trial, in which they looked at patients who progressed on AI CDK4/6, and again, there was positive PFS signal in the EMBER-3 with the single agent imlunestrant versus standard of care fulvestrant, and that also got an FDA approval a couple of months ago. So this is the current landscape that we'll look at for ESR1 mutation. I would say, though, that this is a very specific situation. These are agents that are used at second-line setting after radiological progression will RECIST, our familiar landscape, and if patients have to end up harboring that ESR1 mutation. And I would say in that setting, some of the emerging data as well are trials similar, trials like the combination arm of EMBER-3, in which they actually added abemaciclib to imlunestrant, and that gave a further push to the progression-free survival against single agent. And then you have other agents, there are other trials as well that are testing other oral SERDs in that setting, either alone or in combination.
Yeah. So one fun story about fulvestrant, because I crossed paths with Matthew Ellis also at Baylor College of Medicine, who is the one who said you need to give 2, not 1, because he found out that 1 is an incomplete blockade when you give 1 shot. Even with 2 shots, he found that it's not enough. But he said, I'm limited. There's only 2 butt cheeks, right? I want, ideally, I want 4 butt cheeks, but you cannot have 4 butt cheeks. So we have been limited by it being an injection for the longest time. You're not limited when it's a pill. That's why it's very exciting. But you're right. At this point in time, with the FDA approval, we're limited with those agents. after patient have radiological progression once they're in their second line plus, after ideally receiving an AI plus CDK4/6 inhibitor in the first line setting. So here comes a very important thing. We know from what you laid down, the moment ESR1 mutation emerges, giving an aromatase inhibitor become an exercise in futility. It doesn't work. It truly doesn't work. So the idea was like, can we move those oral SERDs, those degraders, early on when this mutation emerges to improve outcomes? The first one to do it was a study called the PADA-1 study.
Right.
Can you tell us a little bit about the PADA-1 study?
Yeah, I think that was a very smart study. I think Beta-1 was more of a concept, rather than it was some French idea, right? So it starts in France, and it was a open label study that looked at patients who are on the first line setting, ER positive, advanced breast cancer, and instead of looking at molecular progression for these patients, they did something that is quite new and quite radical, really, at that point. They look at molecular emergence of the ESR1. So as you said, ESR1, it seems like when that comes in, patients are not responding. So a natural thought is, well, if I am seeing that mutation, why am I continuing to do this treatment? Can I just do something a little bit better? Now, this concept is not completely novel. There have been trials to look at, for example, residual disease in triple negative breast cancer based on, their molecular pattern. So there are trials that have done similar molecularly target approaches in the past without a RECIST counterpart. But in the metastatic setting, we're always a little bit concerned, a little bit scared. We're always telling ourselves, well, if the cancer is not really getting any worse, why am I taking that, leap of faith? So, but they did it. And in the Beta-1, I believe there was 180 patients, around that number, and they were randomized in 2 arms on emergence of ESR1 to either continue their standard of care AI plus the CDK4/6 or switch the AI to fulvestrant and continuation with their CDK4/6. And the idea was simple. The resistance is not in the CDK4/6 and the AI. Let's switch the AI over to fulvestrant. After the follow-up, the trial came back very surprisingly, a very positive study at a 9-month BFS, it really demonstrated the idea very clearly that no, you actually can have an efficacy once you switch over to a SERD. Now, that has a lot of limitations. One of the main limitations in the Beta-1, I would say, with the fact that it's an open label. It's a little bit tricky to kind of do this kind of study, and also telling patients, facing them that I'm going to give you a drug that we think is not working, therefore we're trying to see if the other one works or not. But you can also look at it from the fact that this has been the standard of care at that point, and it really has been established for a long amount of time. So the hazard ratio came back at, I believe, 0.4, really, eventually after follow-up, an updated follow-up of that study, which is dramatic, given the fact that we haven't really changed anything, and we've used a drug, fulvestrant, that we know works modestly in the ESR1.
Yeah.
The other lesson we learned from Beta is, the interpretation of these numbers is going to be a little bit nuanced. So right now, when you talk about progression, you're actually talking about 2 different things.
Yeah.
There are 2 different cohorts of patients here. At the first radiological progression, one cohort, the cohort that maintained the AI, only saw 1 line of therapy, while at the second cohort received 2 lines of therapy. So this is going to be a point of nuance that will remain in this type of trials, going forward.
For sure. I think you're right. Like the PADA-1 was a very provocative study. It was definitely hypothesis generating. but it was incomplete. But you saw doubling of progression-free survival by switching the endocrine therapy backbone from an AI to fulvestrant, which was really nice to see. But like you said, there was a huge limitation because of the fulvestrant. Number one, is an incomplete blocker of the estrogen receptor. The other one, it doesn't work against all subtypes of ESR1 mutation. Like we said earlier, it has very good activity against the D538G mutation, which is 50% of the mutation, but the other 50% doesn't really have activity. So the idea was, it was a phase 2, it was provocative, but then we finally got like kind of the confirmatory study of the PADA-1, and that's the SERENA-6. Can you let us know about the study design of the SERENA-6?
Well, SERENA-6 is definitely a unique study, right? There is a lot of firsts in this study, and I think that's given it both strength but also logistic applicability challenges. So I think SERENA-6, rose along the shoulders of prior data, specifically beta and data from SERENA-2, which really established Camizestrant as the new kid on the block. So Camizestrant is interesting, right? It's not just purely an oral SERD. It also had the CERAN activity, and we know that it has a much more potent ability to inhibit the estrogen ESR1 mutation at even lower doses. So the agent already has been established itself as a very powerful agent. And we saw again the promising data in SERENA-2, in which it was compared to fulvestrant in second-line setting, and patients have had a pretty good positive data from that trial. There's also the classic SERENA, I think SERENA-4, that is the classic typical first-line setting. So SERENA-6 was envisioned as somehow maybe we can actually target ESR1 better earlier, and that's really where it started. And I think the design was developed as, first we're going to see patients who are first line, who has been on first line for some time, usually 6 months, and made the study design. So that way you excluded your endocrine refractory, right? And then you started doing routine scheduled ESR1 testing. Now, this is not standard of care. This is also logistically challenging in some situations. However, the study managed to do it, which is kudos to the study, because anyone who's been involved in trials know how crazy exhausting, some of these, study activities can be. So every 2 to 3 months, there will be repeat ESR1 testing. And on ESR1 emergence, patients are then randomized to either continue, what they have been on, continuation arm, versus switching to Camizestrant while keeping the same CDK4/6 agent. So there was stratification by ESR1, stratification by visceral status, and in most of these patients as well.
So the exciting part about it, like you said, so SEREN, just for our audience, because they might not know our medical jargon. So when we say SERD, that means it's a selective estrogen receptor degrader/downregulator. SEREN is a complete estrogen receptor antagonizer. So it forms a covalent bond basically with the estrogen receptor. It's not leaving it, and the estrogen receptor becomes out. So that's why it's this agent is very exciting. Now, in the patient population, something that was interesting is that on average, the patient received the first-line AI CDK4/6 inhibitor for 22 months before getting that ESR1 mutation, so they can get randomized. 22 months is very decent, because we learned from the Emerald study that the patient who has a decent response to first-line therapy with AI plus CDK4/6 are the most sensitive to receive an oral SERD after, especially what we talk about after 12 months. The other thing that was a little bit surprising about that study, because not all patients enrolled on the study from the moment they started the AI plus CDK4/6, the idea is 50% of the patients were found to have ESR1 mutation
on the randomization.
First randomization.
Which I think is honestly, that was surprising to me, because typically you hear that you get about 40% of ESR1 mutation, 40% of patients have ESR on the second line setting. It does tell us, however, that, because we don't test, right? So we don't test these at that early level. So there is a good chance that there's a lot of patients who are developing ESR1 mutations much sooner than we actually know about, and we really just don't test it, because we tested the first line at the beginning to make a decision about what we're going to start, if there's an actionable mutation at the very beginning. And then we test like 2 years later, right? Once progression signs started happening. So half the patients were ESR1 at randomization, the other half, developed it with an average of 23 months. Interestingly, also, there was one comment that mentioned that the rate of emergence starts to decline after 30 months.
Yes.
And that's interesting, right?
Yes.
Yeah, that means that technically you're actually looking at some patient population that really these are the ones that you treat in the clinic for like 3-4 years, right? With an AI and a CDK, forgot about them, right? You bring them every 6 months, they're doing fine. You move on to the next patient. So there are some puzzles that we're still figuring out about who are these exceptional responders.
And what's exciting about it, for the first time in a phase 3 study, we're not looking for radiological progression. We are testing molecular progression, which is something very exciting. Our hematological colleague already are more visionary than us. They have already moved it long time ago with the CML, and now going to other cancers like ALL, and recently multiple myeloma got a publication in New England Journal using ctDNA as a surrogate for those. So they're already moving toward this molecular progression. It's time for solid malignancies, right? So that's why this study is super exciting. So it's truly exciting because it met its primary endpoint, right? It improved median progression-free survival. Can you tell us a little bit about the median progression-free survival improvement and a little bit about the surrogate endpoint that are looking at PFS2, and what does PFS2 mean?
Yeah, I mean, again, this is exactly, I think that we're entering great time in which we're having a lot of these fun medicines that really do great job for patients, but we also have to be careful about how to interpret some of these data, because we're going to talk to patients about it. So the study made its primary endpoint. PFS was progression-free survival as defined as from the time of randomization until the time of radiological progression, RECIST progression, which was 16 months for patients who switched over, versus about 9.2 months for those who remained on their endocrine therapy. So almost doubling, more or less, the time time to progression, which is, again, astounding. If you think about that, and remember that, as you mentioned, there's an average of 23 months until that ESR1 mutation emerged. So you take that average, then you throw in another 16 months in there, we're talking about 3-4 years, right?
That's so exciting, because you're squeezing every little thing from your CDK4/6 inhibitor.
Yeah, you're making these patients live longer, healthier, years without thinking about their cancer, just by doing a tiny switch for the right patient. So again, it is empowering, and it makes us feel good. It makes us that we think that we're doing something, and we can see that something that's changed. However, there's some caveats, we have to keep in mind. So although that PFS is fantastic, I mean, if you think about it, right, we would probably anticipate it to be a little bit better. I mean, we would have been very surprised if the PFS was not positive, because we think that the Camizestrant outperforms endocrine therapy in this setting. So the other thing that they mentioned, when we say progression, the cohort that received Camizestrant, that's their second line of endocrine therapy. The cohort that didn't receive Camizestrant, was that their first line. So as the study was developed, and I think the team behind the study was very intelligent, because they had to anticipate what the what the real world, applicability will look like, and then try to work backwards and design in the study how they can address it. They asked, what else can we measure that can demonstrate efficacy here without a doubt? So there are some surrogate measures, and one of them was the PFS2. And then the PFS2 asked, Okay,
Yeah,
fine.
can you introduce PFS2 for us?
Well, I mean, it's in again, in simple terms, it's the second progression, right? Beyond that particular line. So they progress, that's your PFS as defined in the trial. And then BFS2 would be the progression from the time of the randomization until the time of the second progression, second radiological progression. Now, the reason I think that this is a very important endpoint is it is, in a way, not necessarily similar, but it helps as a surrogate for survival. Because if you zoom out, this is a measurement of how long did patients do collectively, right? And if you think that patients who didn't switch had a shorter BFS just because they didn't switch, then you anticipate that to be compensated in the second progression, in their second line. They will take, whatever time, lead time that were taken away from them, and then that will compensate it in the second line. So you're accounting for the early, start that the Camizestrant team had by adding in a BFS2. And the BFS2 came back also in the favor of Camizestrant, which tells you that the patients who didn't receive Camizestrant ended up going in and receiving something in their second line, which is whatever standard of care is, continued to do slightly shorter BFS too, compared to the ones who had Camizestrant in the first line.
Yeah, no, it's definitely very exciting. Now, in the metastatic setting, unfortunately, at this point in time, we are not curing our patients, right? So quality of life becomes of vital importance. And that study showed some of the most compelling improvement of quality of life. If I can keep my patients healthy, living their life, continuing their role functioning, maintaining their health, this is what we want. Can you tell us a little bit about the quality of life metric, especially what I'm talking about, the median time to deterioration when they did the switch versus when they stayed on their therapy? What did we see from that study?
Yeah, I mean, I agree with you. And by the way, this is actually, that was a missed opportunity for BADA because they actually didn't, with a hypothesis generating, but Camizestrant also, the study also did that in a very smart way by collecting all these PROs and so that's quality of life. Now we've seen significant, the PRO, significant improvement, especially one of the biggest things was pain, right? It's the improvement of pain. There was improvement of dyspnea. These are some of the highlights. There's improvement of emotional distress and instability, and across the board, across all the PRO dimensions, there has been improvement in the Camizestrant group. And a lot of people were worried about, if you added this agent earlier on, you're going to have a lot of cumulative toxicity. Patients just did absolutely better. Even the discontinuation rates were less than 2%, across both arms, really. So all in all, when it comes to their PROs and how they did, despite these patients receiving overall more treatments, they actually did much better because you intervened earlier. And I want to throw a plug in here about, the way I think about these particular interventions is it's sort of like how we recommend in lung cancer patients. We have this famous palliative care study, right? Introduce palliative care earlier for your lung cancer patients. I think any agent that can debulk the tumor and keep the tumor's, objective response high and the disease burden low, even if, and I will defend that opinion, even if you did not get a BFS progression, you're getting quality of life improvement.
100%.
And that's what patients care about.
That's the goal. That's the goal.
Dr. Peter Schmidt once said, I will take objective response decrease over, more important to me on a BFS because that's what patients actually 100%. Feel. So going to Camizestrant, and I think that this is, again, another very important selling point is, being able to make these patients treble, overall the typical amount of, from the start of their diagnosis until, their progression, while having them having a much better quality of life.
I mean, that was so exciting. You didn't double the quality of life. You didn't triple, you quadrupled it. If you look at the median time to deterioration, it improved by 4 folds.
Yep.
I mean, this is for me, by itself, like there is a lot of other stuff to love about that study, but this by itself validates what we're trying to do. We're trying to keep our patient healthy so they can enjoy their life as long as possible. And this is something by itself, this metric by itself, for me, I wish it was the primary endpoint. That's how much I love this data. Because you're right, pain is devastating. Pain in the metastatic setting is devastating, and patients have to deal with it, cancer-associated pain. I'm sure all our community oncologists listening to us, this is something you have to deal with. You're a pain doctor on top of being an oncologist. You are significantly reducing pain on that study. Hopefully that with further data, we're gonna learn that this is less fractures in the bones and other stuff. So this is super exciting. And like you said, discontinuation rate is very, very, very low, meaning patients are tolerating it well, are doing well on this therapy. So now let's switch gear to those side effects, because with any new drug, you get new flavors, right?
That's
so
true.
Walk us through side effects. What should doctor expect when they prescribe Camizestrant? Are there some new side effects or new nuances they're gonna have to deal with in the clinic? What are they, what grades they present, and what can we do about it?
I mean, when you look at the data, there were all the hematological side effects that we anticipate. There were few side effects that have been unique to Camizestrant, but the buzzword has been photopsia, right? And, it sounds pretty scary, photopsia.
The name sounds scary.
The name sounds scary. Like the first time I've heard it, and then the first time a patient mentioned it, anything that has to do with the eye, we're medical oncology. We don't like it. But actually, it's very interesting, right? It's there's no structural eye changes. It's reversibility. It's reversible, and it's really nothing more than these little floaters that patients report. As long as you tell your patients this is what patients experienced, and you're not going blind, and you can tell me about it, but again, this is something that time and time again demonstrated to be reversible with no retinal or vitreous changes. Patients just address it and move on. So that was an interesting, and most of the photopsias that were reported were a grade 1. So it's really a mild inconvenience at best. I agree that it's interesting, with each of these agents or the oral SERDs, we're seeing very different spectrum of adverse events. There has been some mild nausea that we've reported. Overall, however, I think that the agent was specifically really well tolerated compared to some other oral SERDs, and actually compared to definitely some other targeted medicine that we tend to accept their toxicity as we move on. A case in point, our PIK3CA famous inhibitors, right? I mean, we take grade 3 diarrhea and grade 3 rash like, it is what it is. What are you gonna do?
100%.
But I think that from a tolerability standpoint, and I've used most of these oral SERDs, they're actually not really that far off from fulvestrant. That is pretty simple, pretty tolerable, with nothing major to speak of.
Yeah. So you're right. The photopsia, like you said, is grade 1. So mainly what the patient are seeing is few seconds of those shadows or floaters at the periphery of their vision. They mainly happen when they transition between a dark room to a light room or a light room to a dark room. So we warn our patient that they might happen, warning them, reassure them. It's so scary if you don't warn them and it happens to them for the first time.
You gotta do it. You're like, hey, this is gonna happen, and believe me, just believe me, it's fine.
It's fine. It just happened for a few seconds, goes away, and like you said, they were grade 1, meaning it didn't affect their daily living. The other thing they also saw, it didn't even make it to this 20% or more side effects, is the bradycardia. Can you tell us a little bit about the bradycardia?
So I think that it was not clinically significant in most of these patients. The numbers are right. The numbers of patients that experienced it were fairly low, that didn't actually make it to the main presentation. And it seems that there is a little bit of a class effects about bradycardia. There was some reports of it with other oral SERDs, but a much lower degree. And honestly, I don't think that it has been symptomatic in any of the patients that have been on the trial to the degree that we have to take it into concern. I don't recall if there was a significant QTC changes. Do you recall anything about the?
No QTC. It was more of a rhythm prolongation. Yeah, so no QTC and no heart block. That's the most important thing, because some people, it was a sinus bradycardia. And again, it was grade 1, asymptomatic. If they didn't do EKGs, they wouldn't have noticed it.
Exactly.
So nobody complained about it, which was very exciting. Now, what excited me about that study really is that it never sat well with me that we are waiting for patient to radiologically progress to change treatments.
Yeah.
I felt that in 10 years from now, and that's when I started practicing, I felt 10 years from now, we're going to look back and be like, this is very barbaric. You're waiting for cancer to start thriving again before you change a therapy. And a lot of time, attrition rate is real. A lot of time, you're not in charge of the situation when the cancer progresses. Patient can be sicker. It can go to some organs where patient, sometimes it can lead to fractures in the bone. Sometimes it can go to the liver and liver can fail. It can go to the lung and the patient can have issue breathing. So if we can find some markers in the blood that telling me that this treatment is essentially futile, it's not gonna work. We know we have so many studies already being done. Once ESR1 emerges, aromatase inhibitor become futile. They don't work. CDK4/6 inhibitor are not going to work on their own. CDK4/6 inhibitor work when you have an effective blockade of the estrogen receptor. You lost that. Once ESR1 emerges, you have lost that. And that's why it's really important to switch therapies. And I feel like it's really important. That study is really important. It's going to make us better physicians to our patient. It's really positioning itself to its future. What do you think, and what do you tell our community oncologists about it?
I love your enthusiasm, but I'm always like the cautiously optimistic. And I'll tell you two things. First off, I agree with you completely. I think it's a new design, a new way to kind of look at things. ESR1 mutations make our treatments inefficient. Waiting for patients to come with pain and aches and side effects and symptoms does sound barbaric. The world is changing. We're now using ctDNA, like tests like Signatera and Guardant, the companion diagnostic for the SERENA-6 study, to monitor in real time, molecular disease and how much disease there is. A Guardant, for example, they do it in tandem, so they will tell you, how much, molecular residual disease there is of the ctDNA, and they will sequence it. So if you're gonna use that as a way to kind of know, your new, VAF, for example, right? You're using that to kind of see that you're actually hitting the target. However, we also know that these agents are inching earlier and earlier, right? So they're definitely coming on the first line. We got all the trials in the first line. SERENA-4. We got other trials with other novel CDK4/6s and novel, oral SERDs. Although one of them actually was just reported negative, the Persevera, which was bizarre considering that the second line and the early adjuvant line were positive. So I'm not sure if that's the companion CDK4/6 or other reasons. However, as these agents are inching closer, that's gonna cause another problem to happen. Okay, well now you tell me we can use it on ESR1 emergence, but hey, you're also telling me that eventually we're gonna be able to use it right from the get-go and the first line setting. So what are we gonna do for these cases? So I think it's a good problem to have. In the meantime, as we are getting more and more of the efficacy of the oral SERDs in the first line setting, we definitely should incorporate actionable treatments for ESR1, because we have not one but two fairly large confirmatory studies that tell us that that is the right thing to do. And then but as we are thinking about that, we also need to think ahead and ask ourselves, what about, in the future as we're bringing these agents sooner into the adjuvant setting. How are we, generally speaking, going to treat breast cancer in this setting? Right, I think I think I'm thinking of SERENA-6 more of a system. It's an idea. It's not just the way that it was designed. It's the idea that we can use molecular targets as they emerge to change treatment.
Yeah.
We do not need to depend on, anyone who does trials and look at the RECIST criteria, the first question anyone have asked, and I've seen it in many patients, like, why 20%? Why do you guys say 20% as progression?
Yes.
Who came up with that 20%?
Yeah.
Is that like a number that was like studied before?
Human-made.
It is absolutely random.
Human-made.
Absolutely random.
Yep.
So if you think that we're basing our decision on treatment on such random, size changes of tumors, while we have tools that can sequence single cell RNA, you know how the disconnect is. So I think that the future really carries this personalized approach in which every single patient will look at their sequencing of their tumor DNA in their blood, will understand what their mutations have. Maybe they have ESR1 early on, maybe they have a PIK3CA or any other mutation or an actionable mutation, and target that and eventually veer away from an anatomical progression.
Yeah, no, for sure. Now, I just want to shift gear. Let's say the drug is approved. I know every time there's something new, there's some hesitancy initially from physicians to adopt it, right? So I see two things over here. The first one is, and I'm going to give you my opinion, I want to hear your opinion. The first one is about, on the study, they did the blood test every 8 weeks to 12 weeks. So every 2 to 3 months, they were checking for ESR1.
Yeah.
That's one. Number two is that they were following molecular, not radiological. We were trained throughout our life to follow radiologic and nothing else, right? So for the first one, I would say for the blood test, the frequency of the blood test, those patients are on CDK4/6 inhibitors, right? They're already getting a monthly blood draw. This is just adding an extra tube to it. And in the future, we're not going to have to run the full panel. They're going to do those droplet tests that just check for ESR1. So it's going to be simple. So I really don't see that's a limiting step. In terms of radiological progression, that's how we've been trained. Everything in life changes. We need to be comfortable with change. We cannot be stuck to our old ways, right? We need to be comfortable with change. Once you get newer data, more exciting data, we need to be accommodating for our patient. Because I feel in this day and age, our patients are definitely demanding more from their oncologist. In this day and age where everything they can get right away, and I blame this to Amazon, right? Amazon, what happened with Amazon, nowadays they want it not only next day, they want it same day shipment,
with a drone.
Right. 10 years ago, we used to wait like 1 week plus, and we used to be happy about it when deliveries come, but right now we want right now. So this study truly fits the persona of patient in this day and age. They want to know right away when a therapy stops working, and they want to switch. And I think patients are really going to like it. What do you think about that? And what do you think are going to be the community oncologist limitation, and how can you reassure them?
Paradoxically, I think a good chunk of community oncologists understand change in treatment based on molecular emergence, because they do that for non-solid cancers. Actually a pretty standard thing. You mentioned CML. I mean, that's basically how they do it. Myeloma, that's basically how they do it. So using blood-based markers as opposed to radiological markers is certainly not novel for them, maybe novel for solid onc. So I think that the adoption rate will likely be higher than what we think. I think the actual limitation, right, really would be in having a discussion with the patient who's doing fine. They're coming in through the door. They're doing absolutely fine on their medicines. They're stable disease, but they have an ESR1 emergence. The problem is going to be in the time it takes a community oncologist to explain that notion that you just said to the patient. I think that's the bottleneck. Because although you're absolutely right, patients would want to get the treatment that is going to work best for them. But what if they feel okay now? So this is how I would approach it. I will tell them that I know that you're feeling good now, but I also now have information that the medicine you're taking is likely going to fail in a couple of months, 9 months, right? So it is up to you. We can do it, the switch now, and you avoid the pains of progression.
Because you're not in control of the disease.
We're not. Yeah. At this point, the ship has sailed, right? This is similar. Not exactly similar, but in a way, it's similar to when we see an MRD positive or when we see ctDNA rising in a patient, with other tests. We know that the disease is declaring itself. We know that the disease is progressing. So I think the real conversations here would be a patient education conversation. Why am I going to switch your medicine? Although you feel good and the PET-CT you're seeing on my chart looks fantastic, but the reason is we have the evidence that it's not working anymore. We're actually, for the first time ever, have more information than the cancer has.
100%. 100%.
Right? And we're in a position in which we can outsmart the cancer.
100%.
Let's jump in and let's actually do it.
I agree. And that's very exciting.
Yeah.
Well, Dr. Elkhanany, that was fun. Thank you so much for joining us today. And for our audience, don't forget to subscribe to Community Health Media, CHM, on all different platforms. In fact, choose your platform that you like. They're available on all platforms for more exciting events like today. Thank you.
Thank you. Thank you for having me.